So hello everyone, welcome to our new online conversation about breast cancer with our guest, Dr. Mothaffar Rimawi, a board-certified medical oncologist specializing in breast cancer care and research, Executive Medical Director at Baylor St. Luke Cancer Center. So Doctor, welcome. We are glad to have you with us today.
Thank you, I'm glad to be with you.
So, Doctor, breast cancer is the second most common cancer in women after skin cancer, and it causes a certain amount of fear amongst women. So, every woman at a certain point of her life has thought about it. Will I have breast cancer, or what should I do to prevent breast cancer? So, my first question will be, first, what is breast cancer, and what are the different types of breast cancer?
Yeah, thank you, Myrna, for this interview and this important question. Yes, breast cancer is a very common cancer, and I think you are very correct in assuming that a lot of women think about it, of course, and we see that firsthand. Breast cancer is essentially like cancer of any other organ, is when cells in the breast glands, the glands that during lactation make milk, these cells can start accumulating abnormalities or mutations in their own individual genes over time, and that results in uncontrolled growth that then starts invading the surrounding structures, and most importantly, can also travel through the bloodstream to other organs, which is really the most serious thing that a cancer can do. And of course, this is why we focus a lot on breast cancer, on identifying it early, because, scary as a cancer diagnosis is, breast cancer, when diagnosed in its early stages, is very highly curable. We're talking about 90% or greater chances of cure. And this is why our message is always to try and detect it early. In terms of its different kinds, there are many different ways to classify breast cancer. One could think of the cell of origin, like did the abnormal cells start in the actual milk gland, or what we call a lobular breast cancer, or did it start in the duct of the gland, or one of the many ducts, which is called ductal breast cancer. This latter, the ductal, is about 90% of breast cancer, is the most common type. And we also classify breast cancer based on the specific receptors or proteins that we check in the cell that can help us determine the behavior of the cancer, and as well as how to treat it, like the estrogen and progesterone receptors, or called hormone receptors, HER2, another protein that's important for cell growth, and the third type is, of course, when it doesn't have the hormone receptors or HER2, or what we call triple negative breast cancer.
Okay, so doctor, we hear about grading and staging when someone is diagnosed with breast cancer. What are they? What is grading and staging, and what is the difference between them?
And another important question. So grade is when we look at the cancer under the microscope. The pathologist looks at it and looks at specific features of how the cancer looks, and basically gives it a score, which results in a grade. And this is essentially to look at how differentiated or undifferentiated the cancer is. Meaning, are these cancer cells trying to behave like normal cells and form glands, or are they just growing without any structure or order? How do the cells look under the microscope? How rapidly are they dividing? And for each of these three components, they give a score, and based on it, the grades are grade 1, which is a low grade, grade 2, which is medium grade, and then grade 3, which is a high grade. So grade is how the cancer looks under the microscope. Stage is how early.
You mean it's the aggressivity of the cancer? This is the grading? So how much it's aggressive?
Yes. So higher grades are more aggressive than lower grades. Now, so stage is how early or advanced the cancer is. So stages are 1, 2, 3, and 4. And actually, some people classify DCIS as stage 0 breast cancer, which is that limited breast cancer. Breast cancer up to stage 3 is curable. Of course, the earlier the stage, the higher the chance of cure. But stages 1 through 3 are treated with curative intent, meaning we're trying to cure them, while stage 4, which is when the cancer has spread outside the breast and the immediate lymph nodes, like gone to the bones or the liver or the lungs. That's when we call it stage 4 or metastatic breast cancer. And that's when we treat with the intent of controlling the cancer for a number of years, but we cannot cure it. We cannot make it go away.
Yeah, okay. So, doctor, who is at a higher risk of developing breast cancer?
Yeah, so breast cancer is a cancer that affects everyone. Of course, women are far more likely to get it than men, but men still get it. But for every 200 cases, women, one case in men. Of course, women have the highest risk, and clearly, and then
this is due to hormones or
yeah.
why?
So it's actually multiple factors. So of course, the breast itself, the presence of the breast, and then of course, the female hormones over a long period of time. So essentially, for example, early menarche, starting the period in a girl or a young woman earlier, or developing menopause at a later stage means longer exposure to these hormones. There are factors related to obesity, or being overweight, alcohol consumption for those who drink. So there are several factors. Smoking increases the risk a little bit, but not by much. It's bad for many other reasons. And then there are factors related to late versus early pregnancy. So in the old days, the days of our great grandmothers, they used to marry, maybe younger, and that actually resulted in protection against breast cancer. Now that, of course, women, are choosing to have children later on after they finish school and have their careers, that could slightly increase the risk of breast cancer. Breastfeeding decreases the risk of breast cancer, and the most important, or one of the most important factors, is family history. So if there is a strong family history of women with breast cancer, then that's a reason, that increases the risk of other women in the family. And if there isn't, then that lowers the risk.
And doctor, can you tell us about the triple negative breast cancer? We know it's considered the most challenging amongst the breast cancer in women. So why first? And it's not, because it's not hormone receptive, I think. So can you tell us about it more? Because we hear about it and it hits women at an early stage. That's why we hear about it more.
Yes, so you're absolutely correct. So triple negative breast cancer, remember we talked about us checking 3 receptors on the cell: the estrogen receptor, the progesterone receptor, and HER2. If the cancer cell has none of those, it's called triple negative because it's negative for those 3 things. And of course, this is the best way we can characterize it. There's probably a lot of, some differences within those cancer cells. Triple negative breast cancer is about 15% of all breast cancer, so it's not a large number. But it is because it doesn't have those receptors for which we have really good treatments. It kind of makes it more aggressive and have fewer treatment options. Until recently, we would give chemotherapy as maybe one of the only options, and of course, if the cancer is still limited, surgery and radiation. In recent years, there's been development in the introduction of immunotherapy, that can actually help these women achieve a higher response rate and a higher cure rate. And then also some newer drugs called antibody drug conjugates, more directed therapy that can help these patients. But all in all, I do agree, it remains the most challenging subtype of breast cancer. And it tends to be more common in younger women, which is to say, it's still not the majority of cancer in young women, but a younger woman has a higher chance of getting it if she gets breast cancer than an older woman.
And doctor, is immunotherapy a promising treatment for all breast cancers, and who is candidate for immunotherapy treatments?
So immunotherapy is very promising. It has kind of changed a lot of cancers that were very, very difficult to treat. There are not breast cancers like melanoma or serious skin cancer or lung cancer and many other cancers. It really has transformed the field. In breast cancer, it entered through triple negative breast cancer, which is the one we just talked about, the most challenging, the one that we have the least amount of treatments for. And it has really improved outcomes in these women, both in women who have early stage breast cancer that we can cure, and then also women with later stage or metastatic disease that by making the treatments, the cancer more receptive to treatment. So this is just kind of one kind of immunotherapy, which are the antibodies, what we call PD-L1 inhibitors. But there's a number of immunotherapy treatments that are in development right now that are very promising for breast cancer and other cancers that will hopefully make the immune response to the cancer better. The way these drugs work is they just kind of, cancers have a way to trick the body and its immune system and to say, hey, we're normal, don't attack us. Well, so it kind of puts the brake on the immune system. So the goal behind immunotherapies is kind of to remove those brakes, kind of remove that trick that the cancer practices on our immune system. So our immune system can then go and attack those cancers and increase the chance of response to treatment.
And doctor, what about the genetic testing? Do you advise women with the history and family history of breast cancer to do genetic testing? I mean,
so genetic testing, and of course, has become more and more common, particularly in the last decade or so, where the technology for it has become more widespread and more affordable. In general, there are some categories that we absolutely think, and per practice guidelines, we recommend they get tested. So any woman age 50 or younger who gets diagnosed with any breast cancer, and then any woman or man of any age who developed triple negative breast cancer. So triple negative breast cancer at any age warrants the test because of its association with some genetic forms of breast cancer. Now, there are people who don't belong to either category, and they could be older than 50 but not have triple negative breast cancer. And we also look at the family history. So someone who has, for example, 2 family members with breast cancer, we always recommend their testing. And a person who has herself 2 breast cancers, if she had breast cancer, then another one, we test them, and many other categories. Yes, but it has become widespread. And we always say, I always recommend that if a woman feels like she has some family history of breast cancer, she's not sure what to do about it, is to talk to her doctor. And there are ways, methods, and tools online and others that the doctors could utilize to see if the treatment is recommended. If the genetic testing is recommended for these women.
So, and if she finds herself with a predisposition for breast cancer, what are the options she has?
So there are, 3 categories now of genes. There are the genes that we call the high penetrance or the highest risk, like the most common ones, BRCA1 and BRCA2, for example. And those are associated with the highest risk for developing breast cancer and other cancers like ovarian cancer, also in men, prostate cancer. So just to be clear, it's not only breast. But for these women, in regard to breast cancer, so they're counseled on essentially either performing what we call risk-reducing surgeries, which is bilateral mastectomy, and then also removing the ovaries when they completed their families. So that's one option. Another option for some women who still want to keep their breasts, still want to have children and breastfeed, or they're just not ready, is to monitor them closer by getting not only the annual mammograms, but also an annual MRI of the breast to screen them more closely and find out cancers earlier, if they so choose. There are also other categories, intermediate and lower penetrance, and those usually the recommendation is to screen them with the breast cancer, with the mammogram and the MRI, and also discuss with them the potential for risk-reducing surgeries, but it has to be individualized and it has to relay on the family history, because even those mutations, the same mutation in different families, could behave differently. So it's a highly individualized decision. So just one sentence is that I don't think that having a genetic predisposition to breast cancer means that the woman absolutely has to do bilateral mastectomy and to remove these organs. It's not a must. I think it's a highly individualized decision that has to be discussed with an experienced physician and take into consideration all the factors we mentioned.
And doctor, what about the rest of the family? I mean, if one, for example, if a family, the mother has a genetic predisposition. What about the daughters, the sons? What should they do in this? Because I know they will. I think I know. For example, some families they will have a paranoia about cancer because they have
Yeah.
this genetic predisposition.
So of course, everyone who's related by blood
Yeah.
to a person who tests positive for a cancer predisposition gene, those people are highly recommended to test. Because, for example, the children you mentioned, the daughters or the sons, have a 50-50 chance of having that mutation. Because, there are 2 copies of every gene, probably one of them has a mutation, so it's a 50-50. Those who don't have it, who test and don't have it, then they're called standard risk, which means they're not immune from cancer, but they're everyone else.
Yes.
Okay, and so they have no extra worries. The people who have the mutation then could go on and start making those surveillance or a close monitoring to detect the cancer early on, or think about other things they want to do, risk reducing surgeries or otherwise. And of course, I would say that sometimes people say, well, well, the lady has only boys, so she doesn't have to worry about them. Well, first of all, these genetic genes could be associated with an increased risk of other cancers, pancreatic, prostate, skin in men. And then also these boys or men can grow up and get married and have girls who could then also have those mutations and really develop breast cancer, or at least the risk for breast cancer. So it's important to test everyone who has access to testing. And nowadays, again, these labs are becoming more widespread, and the access to testing is becoming easier, and more affordable.
But psychologically, it's a very challenging thing to know about. Yeah,
it is. It is, because it's like people, so I always say that, even those who have a predisposition mutation would be, they're worrying about something that may or may not happen. Right. So it's not a guarantee. But I do think it is and this is why I would say, rather than worry, you have a 50-50 chance of needing to worry, right? So at least get tested. And if you're not of those who need to worry, you're reassured. And if you are, then I think, then you take matters into your own hand. And there are things that people could do. We talked about the surveillance. People could also make sure that they eat healthy, that they, reduce or abstain from alcohol, that they lose weight if they're overweight. And do their routine testing, for breast cancer screening and other cancer screenings, and at least they're being proactive, so that if something is found, it would be found early and would be highly curable.
So it's not true that we say that if you are genetically predisposed to have breast cancer, you have 90% chance to in getting breast cancer. It's not 90% or 80%, or is it true? Because I heard many times doctors saying that if you have a BRCA1, BRCA2 genes, you will for 80% or 90% chance you will have breast or ovarian cancer. Is it true?
So BRCA1 in particular has a higher risk for developing breast cancer, and in some studies it was as high as 80%. But I'm not saying that it's a guarantee, but it is high. And this is why in BRCA1 and BRCA2, which is a lower incidence, but still high, and maybe 50 to 70%. This is why we say that those high penetrance genes, the genes that are more likely, that's when we talk to the patient, in a more, earlier about the risk reducing surgeries like mastectomy and oophorectomy, removing the ovaries. But there are some other genes like PALB2, like ATM, CHEK2. So there are other mutations that we found out about in recent years that are not, still have a high cancer risk, but that cancer risk could be 30%, could be 20%, could be 35%. So it's high, and we do need to act on it. But remember that 2 times out of 3, those people are not going to get cancer, for example. So be vigilant, because the standard cancer risk is about 8% in a woman's lifetime. So, 30% is 4 times that. So it's really an increased risk, but it doesn't mean a guarantee. And therefore, this is why I think, one has to think of the individual gene that's mutated and even the mutation on the gene. could vary greatly in terms of the risk of cancer. So a cancer predisposition gene is not the same risk for all people.
Okay. And doctor, is it true if a woman removes her ovary tubes, the chance of getting ovarian or breast cancer will fall down to 50%? Or this is something new I heard about it.
So BRCA 1 and 2. We do have, again, since these are the genes that have the highest penetrance, which means the highest risk for developing breast cancer, and also we've known about them the longest, so we've had the longest time to study them. So we know the following. We know that removing the ovaries, and some people are thinking right now it's really it's the ovaries. Is it the ovaries or just the tubes related to the ovaries? Well, the tubes are really where the ovarian cancer develops for the most part, or at least that's the most recent feeling. But what also was seen is that when people remove the ovaries, because historically we've just removed both, the risk for breast cancer drops about 50%. So when you remove the ovaries, you reduce, and the tubes, you probably remove the risk of ovarian cancer by about 90 to 95%. It's never 100%. There's still a small chance of a cancer developing in the area. If you remove the ovaries, you reduce the risk of breast cancer by about 50%. So it drops from, like, say, that 80% or 70% to half of that. Still high, but a good drop. There are also people who take a medicine, tamoxifen, or other medicines to reduce the risk of breast cancer also with these gene mutations. So that's also a possibility, and that can reduce the risk by a half or so. Removing the breasts, so a bilateral mastectomy, reduces the risk by about 90 to 95% for breast cancer itself.
So here we are talking about
everyone. Yes.
Sorry, here we are talking about women who have genetic predisposition. What about normal women, the women who don't have, for example, genetic predisposition, and they are, for example, in menopause, they are already in the menopause stage? Do you advise them to remove, for example, the ovaries? It's not, this is not...
Yeah, I think any woman who does not have an identifiable genetic mutation that affects her risk for breast cancer or ovarian cancer, there is no recommendation for them to undergo any risk-reducing surgeries. There are people who have increased risk of breast cancer without a gene mutation because of some, proliferative tissue that was found on a biopsy or a mammogram or something like that, not related to a gene. And those women, we can't start them on treatment with medicines like tamoxifen or raloxifene or other medicines that can reduce the risk of breast cancer. But these are women who typically don't have a gene mutation, and we don't recommend surgeries on them generally that they don't need. But if a woman just is what we call standard risk, no family history of breast cancer, and no identifiable mutations, removing the ovaries and the tubes has not yet been proven to result in anything meaningful in terms of that. Now, a lot of times people look at what we call retrospective data or epidemiologic data. They look at large patient populations and they see some trends. Those are generally helpful for us to develop theories on and test, on patients, but they're not usually very definitive in terms of why those associations were made. So you might have seen or read about some of those were like, oh, women who had this surgery are at less risk for something else, but you don't know what are the other factors that were in between that affected that.
Doctor, let us talk about the treatments. For example, if someone is diagnosed with breast cancer at an early stage, 0 or 1, or for example, what is the protocol you use, or it's different for each type of breast cancer? And when, for example, after having, for example, a partial mastectomy, or how does a woman choose what to do after this, after the treatment, I mean? For example, if they go through chemotherapy and the radiotherapy, do you advise them to remove a total mastectomy or what? This is a question that many women ask.
Yeah, no, these are important questions. So for early breast
Yeah.
cancer. So let's just start with stage 0 or DCIS, ductal carcinoma in situ, and that's usually removed surgically.
Okay.
And then if it is removed surgically, but the rest of the breast stays in place, which is usually the recommendation if it is possible, then the woman can receive radiation and then hormonal therapy for prevention if appropriate. Generally speaking, for invasive breast cancer, which is 1, 2, 3, we usually think of it as kind of 2 or 3 different ways. If this tumor is small enough, okay, and the lymph nodes don't appear to be involved, generally those patients go first to surgery. Then after that, we look at the size of the tumor and a couple of, a number of lymph nodes that the surgeon removes from under the arm. And based on multiple factors that I mentioned, the receptors and all that, decisions are made along the lines of whether chemotherapy is needed to prevent the cancer from coming back or not. And then, of course, the role of radiation, and particularly if the breast was kept in place. And then after that, if the cancer is hormone responsive, and then the hormonal therapy, which is usually given for 5 years, sometimes 10. If the tumor is larger, then or the lymph nodes are kind of large and palpable, what we do a lot of times is start by giving the patient some systemic therapy, typically chemotherapy, maybe some anti-HER2, but in some cases also endocrine therapy as another option. And the idea would be to shrink down the cancer as much as possible. And then that results in a smaller surgery, a higher chance that the woman keeps her breast and have a more limited surgery. And then after that, we can then go on to evaluate, does the patient need more treatment, radiation, and then the maintenance hormonal therapy. These are kind of in the early stage. Of course, we talked about late stage or metastatic diseases where you're really treating long-term with the purpose of keeping the disease under control.
So deciding on a double mastectomy, for example, with a breast cancer at an early stage, for example, stage 1 or 0, it's not advised. I mean,
so
or some women will take this chance and when they decide to remove both breasts.
So, of course, I'm a big believer in the patients and the doctors making decisions together. But if we go to the literature, what the medical literature supports and what the treatment guideline recommendations that we put in place, in the absence of a genetic mutation that predisposes a patient for breast cancer, familial breast cancer, there isn't a recommendation for bilateral mastectomy for breast cancers. Okay. Of course, if a woman has 2 breast cancers that are large, it's a different story. But we're talking about the vast majority of them. And actually, it's very clear from the medical literature and from consensus of all experts that doing surgery is really, you do as much as needed, but not more. Doing more surgery does not help the patient be cured.
More likely, it doesn't avoid the recurrence later on.
Exactly. So So if we look at the women who die of breast cancer, 95% of these women who have a breast cancer recur and they die of it, it happens because of a distant recurrence outside the breast, right? So doing more surgery is not going to reduce that. Now, doing more surgery is needed. Again, we talked about the genetic forms of breast cancer, right? Predisposition genes. Also, there are some conditions. For example, there are sometimes women who've had multiple abnormal cells, not necessarily cancer. They've had multiple biopsies on both breasts and finally developed cancers. They're really worried. And, it's a highly individualized decision that's made between the patient and the physician. But I always, the patients who talk about bilateral mastectomy, I try to make 3 points for them. One is doing more surgery is not going to increase the chances of cure. That's very important. And it is not going to, decrease the chance of the cancer recurrence. But it means more surgery, right? Which more surgery, even as surgery is very highly safe, even a small risk of a complication, gets increased. And then the third is reconstructive surgery. Is a really long and arduous process. It's, again, when needed, we'll do it. And there is the skill to do it. But, when not needed, you result in multiple surgeries. So the first one is very long, but there are multiple revisions. And then, the breasts, the reconstructed breasts are, numb structures that resemble breasts. They're not sensitive and have no sensation. So as long as the patient understands all these things, I think they can go into the discussion being well informed about what it means and it doesn't mean to get bilateral mastectomy.
Okay. So, doctor, we know that early detection is still the best way to fight breast cancer. So, and, certain countries, they say, like, for example, you should start having a mammography at 45. Others say at 40. Others say at 35 now. For example, in Lebanon here, they advise to have a mammography at an earlier stage, even age, I mean. So what is your suggestion? Or
this was
when should a woman start her journey with mammography? And
until like maybe the last decade, it was kind of almost set in stone. Like most people get breast cancer screening at age 40 every year with a mammogram. There are some variations on that in Europe. And there's really been, a lot of changes based on interpretation of screening data. To be, clear with your listeners, and people kind of watch this, there isn't really, those things are not black and white in the sense that, when did you detect the cancer? How many cancers did you prevent? What we call stage migration, moving a cancer into an earlier stage. And did that result in saving lives or not? It's a process that takes a very long time to demonstrate those results from the trials. Well, that takes 10, 15, 20 years. By the time you do that, the technology used to screen has become obsolete. And there's better technology. And so people go, well, with the better technology, you can detect earlier, and that can make a difference. So that's the reason why there are really multiple interpretations. But right now, there are different places. Like even in the US, there are different bodies that recommend things differently. So some people say start at age 40 and get it every year. Some people say start at age 45 and get it every year. In Europe, we know that for the most part, like the UK and most European countries, it's 50 every other year. They start at 50 and they get it every other year. And there are also studies that looked at even getting it every 3 years that are not yet mature enough to alter the recommendations. I say, and I'm, it's really, it sounds like a cliche answer, but it is my genuine answer. I think it all depends. I think if we're talking about a woman who basically has very little or no family history of breast cancer, has multiple women in the family who lived a long time, because I know that in many countries, including our Arabic countries, but all around the world, where a lot of details are private, and so you don't know how someone passed away. But if we know that there hasn't been very young deaths in women, right? And nothing suspicious of them having developed cancer, and we know that, and we're comfortable, and that woman has not had abnormal, any issues, I think she could start at 40 or 45 or even 50. And to be clear, the US does more mammograms than Europe, or at least recommends them more aggressively. We don't necessarily have better breast cancer outcomes than Europe in the US. So I think, just talk to the physician and say, here's my risk. When do I start?
I think it's the role also of the gynecologist of
absolutely. So
he could advise women with the tests and everything.
Exactly. And if that's a woman that, her sister developed breast cancer and her grandmother died young, and for example, her eyes, turned yellow, or she looks sick or something, then someone would say, oh, that's really concerning. Let's start you at a younger age. But I would say, as a rule, people say, okay, doctor, come on, give us a recommendation. I would say, do what your country's guidelines tell you to do. If you have to go by one rule. So if the country's guideline, like, for example, I know that in Jordan, the recommendation is 40, and every year that's the national campaign. I would say, if you live in Jordan, do it at 40. If in Lebanon they're saying, oh, start at 35, well, if you're 35 and live in Lebanon, do it that way, because I think the health authorities of every country take the specific circumstances and also the equipment they have, the staffing, because this is a national effort. It's not a small effort. So I would just say, follow the guidelines of your country, unless you have a strong reason not to.
And doctor, we hear about overdiagnosis, especially in breast cancer. What are the risks of being overdiagnosed, and what are the consequences of this? Because we've never heard before stage 0, for example, in breast cancer. So stage 0 is being now detected everywhere. So you hear everywhere a woman who is detected with a stage 0 breast cancer. So I don't know if this is good or bad, if this woman will develop a breast cancer or no. So this is a really
So as we basically, as technology has gotten better, we talked about how it detects things, you know, now with digital mammograms and 3D mammography, and multiple other things, MRIs. So you detect more cancers and you detect them earlier. Now, the biggest question, which relates to the question of that you asked me before about screening and, you know, age of screening. When you screen a lot, you're going to find more cancer. And the question is, were there small, tiny, little localized cancer that would have never developed into anything concerning in that woman's lifetime? That woman would have lived into her 80s and 90s and seen her grandchildren's children and not had any issues. But now we discovered it, and now we have to do something about it. That's the concept of overdiagnosis. Or is it that we're just doing what we call stage migration or stage shift, which means that we're just diagnosing that cancer as stage 0, which could have been, you know, stage 2, for example, or 3 if we didn't screen. And there is really evidence that we are overdiagnosing, meaning that we are uncovering more cancers than we are shifting. Which means that, you know, yes, you're discovering some of those cancers that would have developed later, but now you're also discovering some cancers that wouldn't have ever been diagnosed. And we have an example, for example, in men where they did some autopsies on men who died in their 80s, and they found that although none of these men had been diagnosed with prostate cancer, 50% of them had cancer in their prostate. Now, arguably, those people never needed to be diagnosed because they lived out their normal life expectancy. So how do we address that? I think we are trying. There are a lot of people, including at our institution, we're trying to study what are the unique differences between that stage 0 breast cancer that would have never become anything meaningful, and between that would have become aggressive. And I think we have to study the biology of these cells and to be able to say, yeah, you know, you have something, but you don't need to worry too much about it, or you have something and we need to act on it.
So we have the tools now to say that? We have the
we don't have the tools right now. We're working on it. It's a topic of intense research.
Okay. So great, doctor. Thank you. I don't know if we covered everything. We need to add any advice to the women out there, not to be afraid.
No, I think so. So I think that if, you know, of course, breast cancer is a very that, you know, any cancer is scary, but I think particularly to a woman, there's a lot of awareness about breast cancer, which also results in a little bit of anxiety. Of course, the breast organ is, you know, the breast cancer is, you know, identified with womanhood and femininity, and so therefore there's really a lot of other stressors around that. I would say, you know, the good news is we have really good ways to detect breast cancer early. We have really good ways to actually cure breast cancer with treatments that are becoming less and less aggressive and less toxic. And I would say the best thing to do is go out there, get your mammogram. And if you have breast cancer, you'll be, you know, with fairly simple measures, you could be cured. But before that, to our younger women, you know, take care of yourself, right? Take care of yourself. I know a lot of women take care of their families and their loved ones and their jobs. But take care of yourself. Exercise, you know, take vitamin D and calcium, maintain a healthy body weight, you know, avoid alcohol if you consume it, or, you know, don't drink it, and you know, and really, you know, maintain your healthy body weight. And, you know, if you choose to have children, try to breastfeed them, because that could reduce risk of breast cancer. But besides that, you know, our society is a society usually of faith and tradition. So we'll just all have to have faith that at the end of the day, if we do everything in our power, I think everything is going to be okay. And you know, we're all there for the women, you know, and their journey in trying to prevent breast cancer and hopefully cure it for those who have it. So we're by your side cheering you on. So don't worry.
Thank you, doctor, for your positive message, and we'll see you again soon. Thank you.
Thank you very much.